Hello, I'm Stephanie, and my presentation today will be about eye movement desensitization and reprocessing, or EMDR for short. So EMDR was developed by Francine Shapiro in 1989. She was working with Vietnam veterans who had PTSD and was looking for some kind of therapy that helped them with, that didn't cause so much anxiety, because flooding was the common kind that they did at that point. So she kind of stumbled across the saccadic eye movements, which is the eye movements that change focal points quickly. So back and forth, usually horizontal saccadic eye movements. And she just came across those on accident, but she was also really interested in neuroscience and neurobiology, and realized that they work. So she kept developing a theory. The theory is quite complex. She practiced different kinds of therapy at that point. And so it integrates both psychological theories like attachment, behavioral, bioinformational processing, cognitive, family systems, humanistic, psychodynamic, and somatic, as well as psychotherapies like body-based, CBT, interpersonal, person-centered, and psychodynamic. And she took all of those and put them into a standardized procedure and protocol for EMDR. It's based on the adaptive information processing, or AIP model, which she also came up with. And the premise of that is that every person has both an innate tendency to move towards health and wholeness and the inner capacity to achieve it. When this is blocked for reasons other than organic difficulties or lack of information, it is likely that the experiences have been stored in the brain in a way that does not allow them to connect with any other adaptive information. So maladaptive perceptual distortions, images, feelings, and sensations can ensue. Also, because these aren't stored properly, they are unprocessed, and they often elicit maladaptive responses that don't make sense to the client. These memories are frozen in time and cannot connect with adaptive information that helps them make sense. There's not a lot actually there's nothing specifically where it says this is the relationship between the counselor and client. There's actually been nothing that's been published. But Shapiro has talked multiple times about a relationship being built on trust, how that's really foundational and important, how therapists must be well trained and go through a certified course, and how they should be constantly mindful of the client's mental state and threshold. The general consensus is that there is a therapeutic alliance, and that having a warm and safe counselor is really important to this process. For clients, they must be able to find a safe place. So during the part of EMDR where they're recalling traumatic memories and things like that, they need to be able to have a place where they can go afterwards to make sure they can be calm and get back to a better state. They also must be willing to intentionally access traumatic or painful memories. So that, of course, doesn't work for every client. And they should be ready to commit to a process for 3 to 15 sessions. Sometimes they can be as short as 1 session, but a lot of them go to 12 to 15. The treatment goals are to unfreeze dysfunctionally stored memories so they can connect with adaptive information and be held in other neural networks. That's kind of like the specific thing that EMDR does, is try to retake these memories that are not properly processed in the brain and help categorize them in a way that makes sense to people. So it doesn't mean that the traumatic memory is completely gone, but it just means that it no longer is coming back with all of the fear and uncertainty that is with that memory initially for these clients. Another goal is to remove the negative self-concept that often develops after traumatic events, while affirming positive self-assessments, and then to empower patients to resume normal memory processing to improve their general quality of life. Because a lot of these PTSD patients, they found they couldn't like function in daily living because their memories were just all over the place, and they would instantly be back in like this traumatic time, and then they couldn't just remember some of the basic things of normal life. There's a 3-part protocol, but there's actually 8 stages within that 3-part protocol. But kind of the overview is that therapist leads a client through bilateral stimulation, so the saccadic eye movements or tapping or noise, while talking through the traumatic memories and negative feelings. So first they work on the dysfunctional past targets, and then they work on current distressing events. And then the end goal is to have an imagined future where they can see themselves in a positive way. The 8 different stages, The first one is patient history. And during patient history, the kind of like an environment of trust is supposed to happen between the patient and therapist. And the therapist identifies 3 factors that guide the process. So past events that created this problem, or like the triggering thing. And then current situations that cause or exacerbate distress, and behaviors, coping mechanisms, and practices that are integral to their future well-being. After that, the stage 2 is preparation. And in preparation, patients become acclimated to treatment, and they kind of just learn what they're going to be doing. So they have to feel safe. And the therapist will teach them about, like, here's how to do these saccadic eye movements when they're not recalling a traumatic memory. And here's how you can keep talking while I'm tapping on your legs, or while this thing is vibrating in your hands, or whatever those are, so that they don't get so distracted by some of that they can't actually work through some of these memories. And then the therapist also teaches the client relaxation practices, so that if they do get in a place where they're just way too scared, that there's things that they know how to do to calm themselves down. In stage 3, which is assessment, the therapist asks them questions, and they're supposed to start kind of thinking about a traumatic event, but not actually placing themselves in it. So, maybe if they were a sexual abuse survivor, or war, or things like that, they just kind of think about that. They don't think specifics about the event. But the therapist will say, can you vocalize some of the negative self assessments or beliefs that you have about yourself in that moment? And so they might say, like, I'm weak, I'm in danger, I'm stupid, whatever those things are. And then the therapist has them vocalize emotions, like how they felt in that moment. Like, I was afraid, I felt angry, I felt lonely. And then they have them go through some of their physiological responses. So maybe like, I was sweating, or I was shaking, or my heart was pounding. And then after they've gone through those 3 things, the counselor has them rate on this subject's unit of disturbance, or SUD scale, how disturbing they feel about that. So from a 0 to a 10 on each one of those things. And then they switch to thinking about positive things. So the patient chooses a positive self-belief that is preferable. So, like, instead of that I'm weak and in danger or something, it's I'm strong and safe. Or instead of I'm like a loser and unlovable, it's I'm doing my best and my feelings are valid. And they have to choose a statement that's rooted in truth and reflects the present moment. And then when they do that, then the counselor has them do that scale with the blue arrow there, which is called the VOC, or the validity of cognition scale. And they choose how true they think that is. So like 1 is completely false, or 7 is completely true. And then after that, they actually start going through what people think of as the normal, oops, I skipped the slide, as the normal parts of EMDR, the desensitization. And so that's when they actually think of the traumatic memory, allow themselves to be in that moment. And the therapist leads them through the sounds, taps, and movements until the patient can give 2 positive or 2 neutral statements about the event. And then they do another SUD rating to see where they're at. After that is installation. So now I can change slides. And during installation, they place a lot of emphasis on that positive statement, like the new truth. And the patient must be able to give it a 7 on the scale. So completely true, and meaning they've internalized it as true before they can move on past that. After that is body scan. So the patient thinks about the traumatic memory again, and the therapist watches them to see if they're having any kind of sweating or tenseness or any of those kinds of things that they're noticing. And if they are, then they have to re-go through some things. If not, they can move on. To debriefing and enclosure, or just closure, as sometimes it's called. And there's 2 types of that. One is where they've actually made it through the target memory, and they can give the 2 neutral or positive comments, and the 7 on the VOC. And another is where they didn't make it all the way through, either because the patient hit a roadblock, or because of just like time or something like that. And so then the therapist will lead them through some kind of self-soothing and coping mechanisms, so that they're not like still in that, trapped in that, really scary time. And then after that is reevaluation, which actually is the beginning of every new appointment as well. And they reevaluate the current emotions and physiological state of where the client is at. So populations best served, PTSD, as I said, that was a huge one. Also, they found that with people with generalized anxiety disorder that also have PTSD, it's been really helpful to just lower some of the fear of what's going on around them. Depression, there was a study that out of 8 patients that they did a study on, 7 experienced clinically significant improvement on the depression scale. Substance use disorders that also went with PTSD. And so when they were together, they found improvement in both. And then there's been some studies with children and adults where they did it in a group setting after like a big traumatic thing like a plane crash or an earthquake. And they found that almost all of them didn't have PTSD symptoms 3 months, 6 months, and 1 year later after going through this. Some current neuroscience is that because it's a relatively new theory, they're still doing lots of studies on it all the time. I mean, there were so many I could find, but there's still a lot to learn about it. They have found that there's probably a lot to do with the corpus callosum, which is the part that connects both hemispheres in the brain, because they found that people who are mixed-handed or ambidextrous don't actually respond as well to the lateral eye movements as people who are really right-handed or really left-handed, but they also are less likely to get PTSD from things. So they found that there's probably a tie-in with the corpus callosum. Another study that was really interesting by Bassini et al. They did some actual brain scans on people after going through, but before and after going through EMDR. And they found that the gray matter in the left parahippocampal gyrus, which is the part of, it's part of the limbic system. So it deals with like, stress, and it's connected close to the amygdala and all of those things with emotions and memory processing. It's specifically in charge of memory encoding and retrieval. They found increase in gray matter there, so new neurons developing, and a decrease in gray matter in the left thalamus region, which is the part that relays motor and sensory signals. So it was actually making these things like it was, less real in the moment and traumatic and it was actually changing their brains for these clients. They also, a study I thought was really interesting because I have 3 brothers with intellectual disabilities, and they had a lot of trauma before my family adopted them. And they found that in the study that when they, I think it was 29 patients and 60% of them were not able to be diagnosed with PTSD anymore after going through EMDR, which because so many of the kinds of therapies they've done for trauma are so cognitive, a lot of the time it's not able to be beneficial for clients with intellectual disabilities. And so this one I think is really exciting that there's a possibility that doesn't really matter the level of cognitive ability. And then they've also shown that it can really help with bipolar and some of the highs and lows that go with that. Some weaknesses, it's new, like I said, they don't know exactly how it works. There's been different studies that have shown different things, but nothing is conclusive. Some people have said it could be re-traumatizing if done improperly, which is true. So that's why you need to be well trained. And then there wasn't a hypothesis that it could change positive memories, which I suppose could happen, but the study that they did, that was not founded to be true. And most therapists would not want to work on helping clients change positive memories anyway. In conclusion, EMDR is incredibly helpful with PTSD because it actually changes the neurobiology instead of just masking the problem, which I thought went really well with Townsend's model of not just fixing the fruit or working on the symptoms, but actually changing the core. And this one seems to actually change the problems that are in the brain. It also is really supported by neuroscience. There's long-lasting benefits. Sometimes like 3-5 years later, they were checking on these vets or like sexual abuse survivors and things like that, and finding that they still didn't have PTSD, their symptoms were still really low. And it also can be used with other modalities. So a lot of people they'll do the EMDR for the trauma, but then they'll also use other kinds of modalities of therapy like cognitive behavioral therapy or just different things that go well together to work on the different problems that often come from being in situations that are so traumatic like that. So I have quite a few references. Here's 1 page and here's 2. And I thank you so much for joining me in my presentation on EMDR. I hope you learned something. Thanks.